In preparation for our next class on personality and anxiety disorders, I'm going to provide you with some background on both conditions. There's no connection between them. We just like to give you the information on both of them, um, which we will do in this class. First, I'm going to discuss personality disorders. Personality disorder is extremely challenging in the healthcare setting. They're basically distinctive traits that people have. These traits are fixed and rigid, but they're not helpful traits. Typically, they cause distress and behavioral dysfunction. That's why they are a problem. You'll be able to identify further on as to why these traits could be a problem. There are 10 different personality disorders that I will discuss, but they all share certain patterns. Perhaps the most important is the distorted thinking pattern, and that is the frustrating aspect. It is that you're telling the person something and they're not understanding it. It's in the way you would in the way you would expect them to understand it. The emotional response is equally inappropriate, and those are the problems. Impulse control seems to be either over or under regulated. Either way, they're very impulsive, or they're so called that they're so controlled that they seem paralyzed. Um, of course, all of this leads to interpersonal difficulties. They have a great deal of difficulty making friends, holding on to friends. They have loneliness. These are probably characteristic of every one of these disorders. Some can make friends, but they have very superficial relationships, and that is why we will encounter these types of disorders in a psychiatric setting. Some theories related to personality disorders. Actually, no one really knows where they come from. Sometimes they seem to be related to stressful childhoods, abuse, neglect, and trauma. And it does tend to run in families. And of course, when things run in families, you don't really know if there was a trauma or was there a genetic piece. Um, is it the genetic piece leads to abuse because that's what the families do? It is a cultural thing with families. Who knows? One major change, again, you're not expected to know all about the DSM. It's not necessary for nurses. We need to understand how to handle personality disorders, not about all of the details for the psychiatric diagnosis. In the DSM-5, personality disorders are grouped with all the other psychiatric disorders. The axis distinction was removed. Personality disorders used to be an axis 2 category, and this is no longer the case. So let's talk about the categories of personality disorders. That has not changed from the DSM-4 TR to the DSM-5. There are still 10. I'm going to hold off on borderline and antisocial for now. The reason being is I'll want to discuss them in greater depth later on in the presentation. And why? Well, because borderline and antisocial are by far the most common you're going to see in a psychiatric setting, whether it's inpatient or outpatient. The order that you see is actually the order of frequency you would see these clients in psychiatric admissions. Most books put them in clusters, as you would see in the DSM. I'll focus on borderline and antisocial because those are the ones that you're going to see the most. But first, let's just review the other ones. Dependent. The dependent personality. These type of individuals are really clingy. They just tend to cling to others. They don't want to make decisions. They're very helpless. This is much more common in women. This is the type of relationship that leaves the person paralyzed. They can't do anything unless someone is telling them what to do. The next is narcissistic. These types of individuals have a pattern of grandiosity, either in fantasy or behavior. They have a need for admiration and a lack of empathy. The beginning of this is seen by early adulthood. This person has a grandiose sense of self-importance. And they're preoccupied with fantasies of unlimited success, power, brilliance, beauty, or ideal love. Believes that he or she is special and unique, and they require excessive admiration, and they have a sense of entitlement. The paranoid personality disorder, these folks have a distrust, suspiciousness of others. They suspect without a sufficient basis that others are out to get them. They're preoccupied with unjustified doubts about the loyalty or trustworthiness of friends or associates. And then the histrionic personality disorder. The person with a histrionic personality disorder, they have to be the center of attention. They are uncomfortable in situations whereby they are not the center of attention. Interactions with others is often characterized by inappropriate, sexually seductive or provocative behavior. They show self-dramatization. Their physical appearance is to draw attention to them. These individuals consider relationships to be more intimate than they actually are. And the schizoid personality. These individuals neither desire nor enjoy close relationships, including being part of a family. They're the loners who are happy working the night shift when no one else is around. This person takes pleasure in very few things, and if any activities. They really just want to be by themselves. They for that reason they lack close friends, and they demonstrate an emotional coldness, a detachment, and just a flattened affect. And then the schizotypal personality. These individuals have odd behaviors or magical thinking that influences the behavior, and it's inconsistent with subcultural norms. They believe they have the sixth sense. They are suspicious or paranoid. They have excessive social anxiety that doesn't go away with familiarity. They just are socially anxious all the time. These individuals, of course, you can imagine, would certainly lack close friends. The avoidant, this individual with a pervasive pattern of social inhibition, feeling of inadequacy, and hypersensitivity to negative evaluation. This person avoids occupational activities that involve significant interpersonal contact because they fear criticism and or disapproval. They fear rejection. He or she is preoccupied with being criticized or rejected in social situations. Just as the title suggests, the person attempts to avoid all social situations. The obsessive-compulsive, this individual has an extensive pattern of preoccupation with orderliness, perfectionism, and mental and interpersonal control. at the expense of flexibility and openness and efficiency. Um, this person is preoccupied with details, rules, list, order, organization, schedules. Um, Show perfectionism that interferes with a task completion. Um, it must be exactly right. It must be performed according to the book, or they just can't complete the task. Um, they're excessively devoted to work and productivity, to the point where they exclude any leisure activities or friendships. They're reluctant to delegate. Everything must be under their control. They want to control it all. They're unable to discard worn out or worthless objects. And the person is typically rigid and stubborn. Some of the nursing diagnosis that we can use for any of these personality disorders is a risk for violence, self-directed, or a risk for violence, other-directed. These individuals do experience distress in many settings. If they do not experience any distress, it would not be considered a disorder. Depending on the type of disorder, they may be wanting to hurt themselves or kill themselves. There is a possibility they will attack others, depending mostly on the personality disorder. Distributed through pattern and impaired social interaction, which is really what's going on here. Which of these must be addressed first? I know you all know what is a priority of importance. One thing about these types of individuals is these are the types of people who, when they enter a room, everybody cringes because they know something is about to happen and it won't be good. So, interventions. As you might guess, all of these clients are resistant to treatment. These are fixed, rigid traits in their personality. In order for the client to accept treatment, they have to have the insight to see that things can be changed, and that is extremely difficult. It's a challenge for them to not only accept the change, but to know there needs to be a change. They may acknowledge that um, they hate the way they are, but then when you suggest how to change, it's very hard for them to take that step and say, um, yes, I can do things differently. Uh, for planning, obviously, safety, danger to self or others is first. We want these individuals to participate in therapy. There are ways they can be helped, but it's a long road to get the client through the process, which will improve coping and hopefully lower their levels of anxiety. Um, Generally, with the exception of the schizoid personality, these clients really do have a lot of suppressed anxiety. Some interventions. One thing that is essential is that all staff be consistent at all times. Um, Often there will be meetings to discuss consistency, as all of these personality disorders. These people will try to manipulate staff. It's necessary that all the staff be on the same page. Many times you will have a situation where a staff member may say, "I think I think you guys are too hard on him. I really don't want to do this," or "I don't agree." At this point, it's necessary for the team to collaborate. Everyone must be in agreement. Otherwise, we'll get staff splitting, and that's where the client perceives staff as the good nurse and the bad nurses. The client will come to you and say, "Well, this one lets me do that," and you can imagine what a nightmare this can turn into. Professional boundaries and therapeutic relationships are very important. Uh, you need to maintain active listening. Some of these clients will be on the unit over and over again and start to develop friendships where people enjoy chatting. And this is fine. Always keep it therapeutic. You are the nurse, they are the client. If you let this evolve into more, you're going to lose. This person has a personality disorder, and they will eventually start to manipulate you, and you don't want to challenge the person's autonomy. Remember, these are rigid traits, and it will not be well accepted. You do want to identify the negative behaviors. Point them out. You want to do it immediately. You could say, now look at what you just said, or do you really feel comfortable about that? Do you feel you could have phrased it differently? I mean, as they express themselves, hopefully their personality disorder has less of an effect on them and their interpersonal relationships. Okay, medication management. You guys are all lucky for this one. There are no meds here. There have been no medications specifically found to treat personality disorders. These are just traits that are ingrained into the person's personality, and for that reason, we do not find any specific medication helpful. However, there is symptom management for comorbid conditions. Many people with borderline personality disorder are very depressed because their lives are such a mess. So you may find that they have comorbid depression, and antidepressants can be helpful. Remember, it doesn't treat the borderline, but it does treat the depression, and that's important. Antisocial and narcissistic personalities can be violent. If they don't get their way, they will act out. Sometimes mood stabilizers can be effective. Anxiety is common to most of these clients, and the use of anti-anxiety agents will be warranted. But specifically for personality disorders, there are no medications. Now let's focus on borderline personality disorder. This is the one that you're going to see most in the hospital setting. It's not the most common personality disorder out there. However, it is the one most common for inpatient or outpatient psychiatric treatment. Everyone wants to be loved, and everyone worries that they will lose the ones they love. But clients with borderline personality disorder push this to a dysfunctional extreme. It is this extreme that distinguishes the borderline personality disorder from someone who simply wants to be loved. Their efforts to avoid real or imagined abandonment are frantic. Extremes of idealization and devaluation. These are the people that fall in love and start to wonder, do they really love me? No, they don't love me. I know they don't love me. They start to exhibit anger. They'll actually lash out at the person for the most minute things. They see that as a sign of no, they're going to leave them. It may be a very minor thing. However, the reaction is extreme. What happens with the extreme reaction, they actually accomplish what they feared, as for the person to leave them. No one likes to be yelled at. Leaving a tremendous feeling of emptiness. They will see themselves having the same experiences over and over, and this reinforces their feelings that no one really loves them. This type of behavior continues in every relationship, and the person finally says, I might as well just kill myself. So then they will have suicidal gestures, possibly taking 4 to 5 Tylenol, and tell the person that they took an overdose of Tylenol. They'll be rushed to the hospital, and the other person will say, "I didn't know you felt that way." And the client then has successfully manipulated the individual. Something like 10% of individuals with borderline personality disorder will have successful suicides. Often after the suicide attempt, the relationship will end. These types of things go on and on. Suicide attempts will occur again and again. With individuals who have borderline personality disorder, not always triggered by relationships ending, but frequently that is the reason why. A lot of times, what people with borderline personality disorder will do is self-manipulation, self-mutilation. This is not a suicide attempt. It's really a way to manage anxiety. They will cut frequently but superficially. They'll even tell you that they are not trying to kill themselves. It is usually done on the top of an arm, the legs, or on the abdomen, which they like because you don't see it as much. As it progresses, they might be cutting everywhere. This leaves them with terrible scarring, and as they get older, the urge to cut goes away. However, they're left with these scars. This is an addiction to them. Many individuals with borderline will tell you how difficult it is for them to stop because they feel such relief. And when they feel pain, the pain of the razor blade or the burn of a cigarette, we discourage this on the unit, which is why we take everything away, and we have to watch for this. So some nursing interventions for borderline personality disorder. We want to make it clear right from the start that you are in a therapeutic relationship and not a friendship. Because these clients are seen over and over, it's easy for this to become a friendship. You must be careful and always remember that this type of client can turn on you. They will want to be testing you if they think you are becoming their friend. It's okay to chat, you want to have conversation, but always keep in the back of your mind that this person has a personality disorder and they may not respond in the way that you may expect. They may idolize one of the staff members and devalue the others. They may come to you and say, you're the best nurse on the unit. You're the greatest. You're the greatest nurse here. All of the others don't know what they're doing. And your response should be a very simple statement. You may want to respond, all of our nurses are good. They may go on to another nurse immediately after and say, oh, he or she is a terrible nurse, and you're the only good one here. That's why consistency is essential. Never engage in this behavior, this type of behavior. Stick with your initial response. All of our staff are good. You do not engage in the type of behavior where they're going to do staff splitting. Remember, they're attempting to pull you into their disorder, and you can't allow them. You can't allow that to happen. They are attempting to do staff splitting, and again, it comes back to the behaviors associated with borderline personality disorder. The bottom line is they simply want to be special to someone. However, they do it in a way where they can never become special. This type of client will participate and attend groups and discussions. However, they'll never really understand or internalize the content. They'll have all types of great things to say. However, inside nothing is really happening. The feeling of emptiness is not going to be touched. The behavioral health setting would not be the only place where the client feels welcome, or maybe not to make it so welcoming. as nurses, we tend to think someone comes to the nurse's station, we have to talk with them. Think about it. This may not be true for the client on the outside. The client may say, everyone here is so nice, no one ever talks to me when I am home. We've provided the client with an environment where the client will return again and again and again because people are just so nice. That's why staff consistency, as I repeat, is so very important. Everybody must be on the same page. Now let's move on to antisocial personality disorder. Um, you'll see this quite a bit in the inpatient behavioral health setting. You'll also see this type of individual in the correctional setting. If you do correctional nursing, you will certainly run into individuals with antisocial personality disorder. These individuals have a complete disregard for others. Generally speaking, these individuals have absolutely no conscience. Um, if they participate in any type of ethical behavior, it's only because of external fears. For example, a fear of going to prison. Uh, they have no sense of remorse. To a certain extent, we could all say we have this. We do something bad and we cover it up. You ding someone's car door with a shopping cart and you don't leave a note. And you think, well, maybe you should have, and oh, well, it's okay. Well, it is not okay. The difference in the antisocial is the extremeness of it. You ding the door and you feel bad. You should have left a note, but at least you feel bad about it. The antisocial wouldn't feel bad. They wouldn't feel bad if they smashed the car window, if it suited their purposes. This individual will do a great deal of lying. They will look you square in the face and tell you what they think they should be telling you. Every relationship is to serve their own needs. They don't enter a relationship for the other person. It's certainly to meet the needs they have. They'll appear confident, however, inside they have a great deal of emptiness. And this type of client, they may make friends, but they'll be using them, and they know underneath that it really isn't any friendship. There's nothing meaningful. Some older terms for this type of individual is a sociopath or a psychopath. These are not currently used, however, you still may hear them. Nursing interventions. This is all about setting limits. Often we do have behavioral contracts. They may not have a conscience, but they do know you do this and this is the consequence. You need to know that there will be manipulative behaviors. They're going to lie. If a client with an antisocial personality says it's a sunny day, you best look out the window. There's no reason for them to say anything true or not true. It's just what they think will get them what they want. There's absolutely no point in arguing. Just assume that what they say may or may not be true and go on about your day. There's no point in going back and telling the client, no, I looked out the window and it's cloudy. Obviously, they wouldn't do this about something you can check. They would do this on something that may or may not be checked, and they don't care anyway. They could tell you, they were abused as a child, or that they were just raped, and you could go back and check on that. However, this, it really doesn't matter to them. A large part is anger. If they don't get their way, they can become very, very angry very quickly. And that's why mood stabilizers are used to manage their behavior. One of the things that we have to teach them about in therapy is about their expected values and behaviors. Again, the client may not be able to internalize this information. If they truly have no conscience, we can't turn them, we can't turn them into having a conscience. What we can give them is a sense of expected right and wrong. Moving on to anxiety disorders. You'll see a lot of clients with anxiety disorder, both inpatient and outpatient. Anxiety disorders are far more common than personality disorders. Most individuals with anxiety disorders are not in a psychiatric setting. Many of them just live with them, but they cause a great deal of distress. Anxiety is something that we all have experienced. It's that sense of distress rooted in fear. It's that feeling you have when you first walk into a new classroom, or when you're handed a test and you haven't yet turned it over and you're trying to remember, what you think it is that you're going to need to remember for that test. To a certain extent, anxiety is helpful. Anxiety is what makes you listen to this and come to class. You understand if you don't, that you may not be successful. If you had no anxiety, you would not listen to this presentation because you would just think, "I'll do fine. I don't need to listen." But you are listening to it, so good for you. An anxiety disorder is when things are causing distress. We have previously noted these things all rise to the level where they cause distress in the client. Anxiety is simply the activation of the sympathetic nervous system. It will cause increase in your heart rate, blood pressure, respirations, and there's often a sense of doom. Anxiety disorders is a very wide category in the DSM. We'll look. We're going to just focus on one specifically, and that is post-traumatic stress disorder. The rest of what I will say applies broadly to all anxiety disorders. They are generalized anxiety disorders, stress disorders, phobias, panic disorders. The person with a generalized anxiety disorder is always feeling anxious, or most of the time, to the point where it's interfering with their functioning. Stress disorders, which are abnormal responses to stressors, such as phobias, which are fears, social phobias, fear of being with other people. There are other phobias which are more specific, such as fear of spiders, fear of closed-in spaces, and panic disorders, which are severe, rapid increases in levels of anxiety. Sometimes these are triggered by something, and sometimes they just happen. Nursing diagnoses that cover all anxiety disorders. Anxiety is actually a nursing diagnosis. Usually some perceive stress. The stress may be real or not. However, the person certainly perceives it as such. Ineffective coping we can use for every psychiatric disorder. Very much an issue with anxiety because clearly they are not coping well, or they wouldn't have the distress. Nursing interventions for anxiety disorder. Don't minimize it. The individual who's having an anxiety attack is very frightened. It's terrifying. They're breathing fast. Their heart is racing. To tell them to calm down, they already know that, and if they could calm down, they wouldn't have the disorder to begin with. So no, they can't just get over it, and it is a frightening experience. And even if they have them frequently, it's still frightening. I guess our goal is, we really want to help them avoid triggers and sometimes avoid the triggers. Other things is to work on relaxation skills. Obviously, you don't want to attempt these when the person is in the middle of an anxiety attack. But when the person is calm, say, well, the next time before it starts to escalate, use this relaxation skill. Lifestyle changes can sometimes be helpful. Exercise is very helpful. Certainly, the person should be encouraged to avoid alcohol because alcohol can increase anxiety. It also acts very badly with the medications that we use for anxiety. So we strongly discourage self-medicating with street drugs. Caffeine and nicotine can increase the heart rate, and look for the sources of stress and avoid those types of situations. For example, if financial situations create increased anxiety, the person should consider lifestyle changes that will decrease that level of stress. Medication management of anxiety disorders. With anxiety disorders, we do have a lot of medications. The first choice for management of all chronic anxiety disorders are the SSRI antidepressants. These are the same ones you've seen in your that we've talked about in the depression lecture, and are the in the SSRI category. These are very useful for long-term anxiety disorders. For short-term anxiety, we're going to talk. The use of benzodiazepine agents are highly effective. Lorazepam, alprazolam, and diazepam. These are the medications that should be limited to short-term use. There are some issues with the use of benzodiazepines. They are very dangerous medications, partly because they work very, very well and are highly effective. The SSRIs take 4 to 6 weeks to become fully effective, and they are still not as effective. So people love benzos. People with anxiety will just love the benzo because they work. You take one, and then 30 minutes later, you're feeling really good. You take fluoxetine, and 4 to 6 weeks later, you're still not feeling half as good. The problem is that these medications are very addictive. It's both a physical and psychological dependence. If you're using benzos regularly, they should be withdrawn in a medical setting because there is a risk of seizures during the withdrawal process. Psychological dependence is because of rebound anxiety. These medications really decrease the level of anxiety. Xanax is like the second most sold medication, and that's not an indication that it's a good drug. The problem is you take it, your anxiety goes away, you wait a while, your anxiety comes back, and so you before you know it, you're using it all day. If you try to stop using the medication, even after you've gone through the medical process, so you don't have the physical danger, you'll still notice that the anxiety is very high. Trying to teach that client that anxiety will go away is difficult. Anxiety is one of the most uncomfortable things you'll ever experience. No one wants to be anxious all the time, and that's something they're going to have to live with. So it takes a great deal of teaching, and it can be done, but it's very difficult. And other things, as you may guess, because they are addicting, is that you need increasing doses, and that can often lead to a problem with prescribers. The prescribers are not going to prescribe anymore, and that often leads to the client looking for drugs on the street, or often they may start provider jumping. going from one provider to the next to seek someone who's going to prescribe the medication for them. So I'd like to focus on one specific anxiety disorder. It's very important to me, having seen many instances of suicide with our veterans returning, and that's the post-traumatic stress disorder, or PTSD. It's a response exposure to severe stressors. For anyone working with the veterans, you're going to see this often. However, it's still seen in all hospital settings. You will see a lot of combat veterans. That's why the VA has become so involved in finding ways to manage PTSD. It can also be seen following natural disasters, earthquakes, or tornadoes. PTSD is seen following physical or sexual assaults, following rape. It's very common. And it can also be seen following medical or surgical care if something went wrong or what was anticipated was worse than expected. So the symptoms of PTSD, generalized anxiety. The person is just very fearful. The hypervigilance. You will especially see this in the veterans. They are always watching behind them, and for good reason. In combat situations, maybe they always did need to be looking around. Perhaps they were on a patrol and had to be alert for IEDs everywhere. They may have seen a buddy get blown up by one, or understandably, they would they wouldn't exhibit this kind of behavior if if they hadn't had some kind of traumatic experience. However, now they're home and they can't let that hypervigilance go. They may be in a grocery store or in line behind someone, and someone makes a loud noise and they jump back and punch someone. Then they feel badly because they know they shouldn't react that way. But it's hard. They'll often have flashbacks, nightmares, re-experiencing whatever the trauma was, and they'll experience intrusive thoughts all the time. The biggest problem is with alcohol and drug abuse in an attempt to self-medicate and decrease the flashbacks and nightmares. This is what will often lead the individual to the healthcare setting. So some nursing interventions for the client with PTSD. In many ways, PTSD is treated like other anxiety disorders. We want to acknowledge the client has experienced trauma. We want to refer clients to counseling that is specific to their trauma. For example, sexual assault, we want to send them to sexual assault survivors counseling. A veteran would be better off at the VA Veterans Administration. The VA has various resources for veterans that can be reviewed through their website, and it's important to acknowledge that they do have a problem. So we do medicate for PTSD, again, with the Ssri antidepressants. Two of them that have been specifically approved for PTSD by the FDA are Zoloft and Paxil. These are very widely used. They do use other antidepressants such as Wellbutrin, but that would be off-label, whereas the Zoloft and the Paxil are approved for the treatment of PTSD. We need to teach people that it's going to take 4 to 6 weeks before the full onset of their effect, and hopefully that they will feel some effectiveness following a week or so of treatment. It is gradual, and for this reason, the benzos are sometimes used for short-term treatment if the person is really having really severe anxiety, they'll do the benzo short term, and while the other antidepressants are kicking in. So it's a long road, and it's something that we need to focus on, especially for the veterans that are coming home. Uh, so that is it for this week, and once again, I look forward to seeing you in class.